for Training and Research and the Global Surgery Foundation. And on behalf of our co-sponsors and co-hosts, the program in Global Surgery and Social Change at Harvard Medical School, and Kids OR, and also Johnson & Johnson, I'd like to thank our co-hosts and co-sponsors for helping make this event possible. My name is Dr. Jeff Ibbotson, and I'm with the Global Surgery Foundation and Unitire, and we're quite pleased to be hosting this special event, the 5th of 7 events on the NSOAP manual. And with me today as a co-host is Dr. Rosemary Mugwe, who is based in Nairobi, and she's with Kids OR as their Africa Director. So I'm just going to give Rosemary a few minutes just to say hello and greetings from Nairobi, and then I'll turn it over to our moderators in just a minute.
Thank you, Geoff. Greetings from Nairobi, and on behalf of Kids OR, I'm really honored to co-host this event. We recognize that NSOAPs are the first step to commitment to improve surgical outcomes in an equitable manner, and including children's surgery, which is an agenda that we really care dear about. As Kids OR, we will continue to support countries to create and expand their pediatric surgical capacities, which we believe effectively impacts on the country's economic growth as well as individual prosperity. Thank you, and I look forward to a lovely session. Over to you, Geoff.
Thank you, Rosemary. And now, without any further ado, I would like to introduce our co-moderators. First, I'll introduce Dr. Zach Fowler, who is a senior fellow at the program in Global Surgery and Social Change at Harvard, and he's based in New York. And then also Dr. Liz McLeod, who is coming to us from Melbourne, and she is a general pediatric surgeon based at the Royal Children's Hospital in Melbourne. So to Zach and Liz, I'd like to turn it over to you to carry on with our session. I'm really looking forward to this, this session of Ministry of Health perspectives on the NSOAP and how to customize this process to our own country. So thank you very much. The floor is yours, Liz and Zach.
Great, thank you, Jeff. Thank you for the introduction. Hello, everyone. I'd like to welcome everyone to the next webinar in this series on National Surgical, Obstetric, and Anesthesia Planning. The topic for today's discussion, as Jeff said, is going to be Ministry of Health perspectives on strengthening surgical and anesthesia care. We'll be hearing from a very impressive group of panelists who have a wealth of experience and leadership in improving surgical care and health systems and really advocating for this on a global scale. They each bring firsthand experience in surgical system strengthening and policy development in a variety of settings. And I think that will really allow us to better understand the role that ministries of health play in national surgical strategies as kind of the main drivers of this process, and also help us learn about how NSOAPs can be adapted to each country based on their unique needs and priorities. So it's a great honor to be able to co-moderate this session with Dr. McLeod and to introduce the speakers. We have a busy agenda today and a great discussion planned, and we'll be taking some questions from the audience at the end, so please feel free to use the chat function and type any questions you have as they come up. And I think I will start out by introducing our first speaker. Let's see, Dr. Howard Sobel is an internist and pediatrician and a preventive medicine physician and coordinator responsible for safe and affordable surgery, quality and safety, infection prevention and control, and maternal and child health at the World Health Organization Regional Office for the Western Pacific. Dr. Sobel has worked at WHO headquarters, Guyana, Ghana, Taiwan, China, Philippines, and Cambodia, and is currently a WHO Regional Office Coordinator. He focuses on operationalizing and scaling up evidence-based programs that save lives across the lifespan in low and middle income countries. As regional coordinator of the Safe and Affordable Surgery program, he's in a unique position to share some lessons learned from the Western Pacific region and the role of WHO in improving surgical ecosystems. So with that, I'll hand it over to Dr. Sobel to give us an overview of his experience.
Thank you very much, Zach. It's a pleasure to be here to work with you, and maybe we can go to the next slide. So the outline of the talk is going to be an overview with a micro video, safety, accessibility, the regional action framework for redesigning surgical ecosystems. That's not the title, but that's what it's about. And post-COVID-19 for the future. Next slide. Can you click on it?
Safe and affordable surgery is essential to achieving universal health coverage. But many people in our region cannot get the surgery they need. In some countries, more than 1 in 3 people cannot access basic surgical procedures within 2 hours, such as cesarean sections, laparotomies, and management of open fractures. The cost of surgery puts some people at risk of financial hardship and poverty, while safety and quality of surgical services are also critical concerns. In some countries, 1 in 100 patients die after surgery. Often, approaches used to address these challenges are piecemeal and uncoordinated, resulting in limited local ownership and inadequate strengthening of health systems. WHO has developed the proposed action framework on safe and affordable surgery to support countries in the region, to redesign health systems, reduce inefficiencies and incorporate innovation. Based on a shared national vision developed by stakeholders within and beyond the health sector, the framework guides countries towards building strong surgical care ecosystems. COVID-19 provides an impetus to make these changes because investments in surgical care have long-lasting impacts on infection prevention and control, hygiene resources, and critical care. This will, in turn, improve availability and quality of many other essential services. Now is the time to strengthen health systems by making safe and affordable surgery part of the new normal.
Thank you very much. So we saw that in the micro video that in some countries, 1 out of 100 persons dies during that acute event of the surgery or perioperatively. And this reflects a combination of problems with safety and access. I'm sure I'm not telling you anything you don't know here. Let's move to the next slide. A lot of this is just going to be what you know, but I'm going to put a different perspective. We need, for surgery to be safe, we need a lot of systems to be in place. This is a study we did looking in delivery rooms, postnatal care wards, neonatal care units, and some recovery units from post-op cesarean section. And we find the same problems across all of them, that we have a lot, most of the places in our region have sinks, but when you dig deep, you have a slight drop off for running water, and in soap it's a lot more. And then when you look at hygienic ways to dry their hands, this is the one that is hugely problematic. And you can imagine when people don't have ways to dry their hands that's hygienic, they're going to be wiping it on anything nearby, namely their clothes. Can't be good. Next slide. I should have mentioned in the previous slide, there was 147 hospitals across our region. In this slide, I just wanted to highlight that safety can be improved in all countries. In this case, this is Japan between 1999 and 2014. And the kickoff case was where a heart patient got a lung surgery and a lung patient got a heart surgery due to patient identification and transport errors that happen. And these happen very commonly that we don't see it, but in this case, it was in Japan, so it caught a lot of attention. There are cases, following that, there were several other mishaps that came to light, such as disinfectant instead of anticoagulants being administered intravenously and oral medication being given intravenously. And 8 patients died from one doctor over a span of 14 years doing a questionable surgery. Next slide. So if it can happen in Japan, I think it can happen anywhere. And Japan did a series of steps, and I think it's really important that when we're doing safe and affordable surgery, that it's not a static process. We don't do one thing and we're done. It's a continuous process. It's a dynamic process. And they kept on doing things in Japan, this is at national level, where they kept on identifying new things that they needed to come up with policies and ordinances on, and they kept on working on them. And I won't go into further detail about this, but next slide. And likewise, at that hospital with the 8 patients that died and countless others that died from other things under the care of that doctor, it had an external group come in. They looked at it. They came up with a set of recommendations, and the hospital was monitored. It was taken off of accreditation and told, here are the things you need to do to get back to be accredited. And they did it, and you had a vast improvement of any number of the indicators. And let's go to the next slide, because this is a nationwide indicator. Next slide. Yeah. This is surgical site infections in Japan. And over the period of 2007 to 2019, there was a 40%, almost 30, a 39% drop in surgical site infections nationwide. And this was due to basically, it was national level and hospital level monitoring toward improving that. Next slide. Now, anybody that works in low and middle income countries can almost guess when you hear about surgical site infections or neonatal sepsis outbreaks or anything that that's dealing with sterility of equipment. The first thing that should come to mind is the autoclaves are being stuffed too full. The second thing is maybe the pressure is not high enough in them, but we tested and we were able to show, in this case, this is last week that we identified this. And immediately my point was that open up the packs, look at them, look at the strips. And we found that, in fact, on the outer strip, everything was fine. But when you looked at the strip that was inside the middle, it didn't get disinfected. But when they then decreased the load drastically, it worked. So in the middle slide, you can see that it was still, the equipment was still wet, even though it's sterile. Same thing is not shown here for sterile cloths and other things like that. Let's go to the next slide. So one of the key places that I think is critical is to look into accreditation, licensing and accreditation. This is both for facilities and for human resources. And I'm not saying we're nowhere near perfect in our region. Volunteer accreditation standards rarely work unless they're backed up by a number of other things. And the renewal licensing for human resources for medical doctors, it's annual in many places, but then when you get beyond annual, it becomes something that you no longer can regulate it so effectively. Next slide. I won't go into much detail on this. I just wanted to say that, as mentioned, that of our Pacific states, we had 6 of 14 Pacific member states that met the target of having to bellwether procedures within 2 hours. That's 2017 data. Next. And we had 5 of 13 having at least 5,000 surgical procedures per 100,000 population, and 6.8 million operations were canceled or delayed due to COVID-19 in just 13 member states. We need to be thinking in terms of resilience and making robust systems so that when we get into these situations, that at least the critical ones don't suffer. Next slide. And financial barriers, it really depends on the place what the financial barriers are. When you look in one part of it, it's much more of out-of-pocket expenditure. You look in another part, in this case, we look in overseas medical referrals, and it's a huge expense. But that also is something that if we can catch a lot of these things earlier, we can reduce the need for the overseas medical referral, or at least it'll be a lot more planned and things like that. And on one of the points that I wanted to bring up is in it's not that expensive when you look at it for disability adjusted life years. It's comparable to many of the things that we use routinely. Oral rehydration solution is far more expensive per daily averted. Next slide. To wrap up very quickly, one of the things that I've observed, not just in surgical care, but across many, many agendas, is that these are often uncoordinated, unrealistic agendas, plans, and strategies with limited ownership to some advocates, inadequate focus on strengthening of the health systems. It's often not done by people that understand the health systems and what is needed in it. That the national allocation is not aligned with subnational burden or critical priorities, and poor communication between levels of the health system. So to strengthen surgical care systems, we need better engagement with stakeholders within and beyond the health sector. We can go into that a little bit more detail in Q&A if we'd like. Using epidemiology, local knowledge, and this is really much more local than national that's critical here, to get better allocation efficiency and strategically strengthen, expand, or allocate elements of the surgical care system within the different areas at our disposal to maximize efficient use of our scarce resources. Next slide. So the action plan, the action framework for safe and affordable surgery was passed in our regional committee in October of this year, and it had overwhelming resonance with the member states. So we had the most number that were making interventions at any time in recent history. Next slide. And the basic, I won't go into much detail, but basically there's 4 operational shifts, and one of them I've mentioned about identifying key stakeholders within and beyond the health sector, develop a shared vision for what is needed, redesign and innovate existing systems, and monitor and use data for action, and in the middle are all the things that are needed within that. Next slide. And this gives a bit of the structure. It's a little bit different than the 6 building blocks, although you might look at it and say think it's the same, because it's much more of a dynamic process than a static process. It's one that has to be done. It's something that has to be worked on. All these elements need to be put together, just like with your with the 6 building blocks, but there's much more of local adaptation. Some things are just not that important, and other things are much more important, and it needs a lot more understanding of, so for example, financial flows is a critical area. I don't know anything about it, but I have people that do, and so I bring them into that discussion. Accreditation and licensing are things that I mentioned previously, clinical audits, quality improvement. And this feeds into the critical things for safe and affordable surgery at the service delivery level. Let's move to the next slide. And this is my last slide. It's thinking ahead. So to recap in some major points, every country can improve safety. There are many things at our disposal, and we may or may not know about them, ranging from standards, accreditation, reimbursement, and management mechanisms for quality improvement. There are many strategic ways that we can deal with improving access. And let's keep in mind, I think this is not lost on anyone, COVID-19 is going to be damaging to the fiscal space that we're going to have, both for the donors and the recipients. So we need to be planning with that in mind. So, but at the same time, many surgeries are cost savings. So if we can sell it in the right way, we should. And health systems need redesign to be more efficient, robust, and resilient. And surgery can be the pathfinder to make all essential services accessible. You saw that in the micro video. Everybody knows someone who received or needed surgery. This is a key point. We need to better appeal to them, we need to find the ones that are most critical to this and appeal to them. With that, I stop. Thank you very much.
Thank you, Dr. Sobel. That's great. I'm one question just quickly, and more no doubt in the Q&A at the end, but the Western Pacific really is the first region to include safe and affordable surgery as an agenda item. And could you just briefly tell us how that came about?
Yeah, I mean, it's nice to have four ministers of health who are, or three ministers of health who are surgeons, and one deputy minister of health who is a surgeon. That helps us quite a bit. But the resonance was just simply there. Countries recognize that this is the last frontier for primary health care. And when we started bringing this up, everybody thought this is something that we need to do, we need to work on. So I think it's I had the easy job on this one. It wasn't easy, but it was much easier than all the work that led up to it, where everybody was saying we need to do this. And then Liz, thank you, and thanks to Zach, and thanks to all your organizations who helped us in crafting the regional action framework. It was very helpful.
We have now been joined by the Minister of Health for Fiji. So
thank him for me. Thank him for me, because he's one of the reasons that we were able to get this through.
Indeed, indeed. So it gives me great pleasure to introduce Minister Ifrani Wanganabete, who's joining us from Fiji. Dr. Wanganabete has a background as a general surgeon, and prior to his political appointment was an associate professor of surgery at the Fiji National University. He's now entered politics a couple of years ago, and is now the Minister for Health and Medical Services. And Dr. Wanganabete has been a very strong advocate for surgery in the Pacific, in particular in the small island states, and is a current president of the Pacific Island Surgical Association. He also, and very dear to my heart, is a champion for the training and advancement of women in surgery. So thank you very much, Wanga.
Thank you. Thank you, Liz, and thank you, distinguished panelists, for this opportunity, and a very good morning from Fiji. And it's nearly 1 o'clock in the morning here. I just want to move quickly through the slides, and then we'll answer some of the questions that we've been through. But very quickly, I know we've got COVID-19 prevented, but we've nearly gone 220 something days from our last case of community transmission. And I just want to show that because currently in Fiji, our backgrounds in terms of those of us who are leading the fight are truly not only in public health, but also from clinical medicine, including an orthopod who's our chief medical advisor and an obstetrician who's now our permanent secretary for health. Next slide. Thank you. We've seen it as, in terms of our COVID-19 containment, in two areas, and we're looking at it from a fresh look as clinicians, but also working with our public health colleagues. And so we know there is an external threat, and basically, the challenges that we have with with people coming back into the country, and border health and quarantine protocol. And with the next slide, we also know that there is an internal threat. And this internal threat is making sure that we keep on second guessing ourselves and going back and essentially like looking after a very sick critical patient in ICU who's had a big operation, and going back and asking ourselves, what could have gone wrong. Next slide. So going back to what we're talking about today, I think those numbers are key, and really, we understand that from the Lancet Commission what the numbers are, but essentially surgery is an indispensable part of healthcare. Next slide. And we also know where the challenges are, and really the challenges are in the low middle income countries and small island development states where Fiji and the Pacific region are in. Next slide. And again, if we look at the NSOAP progress, I believe there's a lot of work that needs to be done. We've been able to champion safe and affordable surgery to now be anesthesia and obstetrics to now become an agenda within the regional committee meeting. But we still got a lot of work, not only within the regional committee in the Western Pacific, but also right across the world. Next slide. And we all understand what the NSOAP framework is about. One thing that is really certain in my current role is that it also needs the political will. And that is something that we need to get all the countries in the world to have a buy-in, is to get the political will to make this actually work so that we can actually go through the wheel of the framework. Next slide. And in the Pacific, as you know, our progression has been from that initial Lancet commission. We have the Lancet indicator collection within the Pacific, and the Royal Australian College of Surgeons have been very instrumental in helping us to do this. And then certainly, as we all know, we've had that World Health Assembly, the side events, and we've championed it in the Pacific Island health ministers, and also in terms of the Western Pacific region, which now has a regional action framework, and also making sure that it's part of an ongoing agenda within the Pacific Heads of Health meeting, which is essentially the chief executive officers of health, the general managers of health within the Pacific. And we've had NSOAPs in 5 countries, and those are the 5 countries that have had NSOAPs. Next slide. And I just want to thank the Harvard Group for also supporting us with Australian College of Surgeons. So we all know what the global surgical indicators are. Next slide. And this is where we are in the Pacific. So certainly you can see there are still some challenges in getting across the line in terms of access to bellwether-capable procedures. And remember, within the Pacific region, we're looking at countries who may have many islands, a couple of hundred islands scattered over a large ocean. We call ourselves the Blue Continent, or the big islands like Papua New Guinea, Solomon's, Vanuatu, and Fiji, which has a big hinterland and mountainous regions, and these can also have challenges with access. Next slide. And we also look at the density of SAOs, and you can see there's a significant difference between Australia and New Zealand and those of the Pacific we have there. Then when the numbers are greater in the Pacific, we also have to remember these are very small island populations. So, small populations, 15,000 people or so, and so their numbers may be construed because of the small population. But essentially, those are what the numbers are with the SAO. Next slide. And if you look at the global comparison, the densities of SAO, the numbers that in the Pacific are similar to the other low and middle income countries and and small island development states across the world. Next slide. And with the volume of surgical procedures, again, Australia and New Zealand, and if you look at the small countries, which are very small countries with small populations, again, the numbers are larger, essentially because they are small countries and compared to where the bigger countries are. Next slide. The perioperative mortality, and now going straight on to the Lancet Global Surgical Indicators 5 and 6, which is the catastrophic expenditure for those who are at risk of catastrophic expenditure. And you can see that there's still quite a significant number of countries in the Pacific that are struggling. Fiji is about 20 and 22% respectively. Next slide. And if you look at the global comparison, again, it's similar to the low and middle income countries around the world. And I've just summarized it into the table, and they are available to be seen later if you like to look at. But right across the Pacific, you can see it is actually quite diverse, and there are challenges that are right across many of the nations in the Pacific, and compared with New Zealand and Australia at the bottom. Next slide. And also 5 and 6 on expenditure. So moving forward, I think the next few slides are the important ones. Moving forward, the opportunities are that for regional collaboration, alignment with wider agenda of universal health coverage, and overlap with disaster and pandemic preparedness. We're now into the cyclone season in Fiji and many other countries in the Pacific. One thing we've been talking about in Fiji over the last few years is the fact that we cannot move our coordinates. We know we're going to be hit by cyclones. We know we're going to be hit by storms because of climate change. It's just making sure that we are prepared. And NSOAPs are a very important part of our preparedness. The challenges that exist is the geographical isolation, the small populations, the inability to be able to keep specialized workforce. And in Fiji, we've been fortunate to be able to do so with the remuneration that's in place for our doctors and the limited access to markets. Next slide. And so what we are doing in Fiji is current and future plans is within the next few weeks, we'll be appointing our chief surgeon or national coordinator to take this forward for us, making sure that it's aligned to the national strategic plan in putting it into our ministry's annual operation plan. So you can see that the political will needs to happen, and then it needs to be inserted into the plans and aligned to the national strategic plan. And we also want to make sure that we continue to support our ongoing professional development and also retaining our staff, because you can train as much as AEOs, but if you can't retain them, then you'll just be losing them. Next slide. And with our health system strengthening, so we certainly believe that the NSOAP development actually strengthens the whole health system, including the ability to be able to reach the rural and maritime areas, and also collaborating with development partners and those who are willing to work with us. Next slide. So what is it, the NSOAP to the Ministries of Health? We need to understand that safe surgery, obstetrics and anesthesia is a public health issue of great concern, requiring a comprehensive approach similar to an epidemic. It has to be approached as a public health issue of great concern. Now, all facets of the health system will be scrutinized, assessed, and gaps identified by doing an NSOAP. But the beauty about it is a starting point for development. And because it is a starting point, we have something on paper. It is a development partners can then be given a plan of action. And the pathway to improvement will also allow the next cohort of the health leaders, especially in small island development states where there's not a lot of us, to participate, embrace this, and own it. And as I've alluded to earlier, the whole health system will be strengthened. Next slide. And what is the benefit of regional approaches to NSOAPs? Pacific Island countries are small economically, so I'm looking at the pros and cons. So on your left are the pros. So with the regional approach, the beauty about it is that you develop a critical mass, especially when you regionalize a particular effort. The use of existing regional organizations to support the cause. So in the Pacific, the South Pacific Commission, for example, or the Pacific Island Forums, those are regional organizations that can be used to be able to put through this. Working with development partners, and development partners like regional strategies. They like to support them. And also, there's a lot of regional groupings around the world where people are beginning, or countries are beginning to say, let's work together so that we leave no one behind, rather than that being just a universal health coverage discussion that happens within the nation itself, but also there are regions that are saying, let's move together. And this is, and this may be why it would be nice to have a regional approach. And the experiences can be similar. But on the other hand, the challenges are, we have to remember when you have a regional approach to NSOAP, that each nation is a sovereign nation and there are competing priorities, and governments do change, officials do change. And we need to make sure that when we begin to look at it from a regional approach, to actually make sure that we lay pillars and principles that can stay despite whatever happens within any individual nations. We also have to remember this cannot be a scorecard. We cannot use NSOAP as a scorecard when we work it as a regional approach and say, yes, this nation is doing better than that. It has to be seen as a mechanism for supporting health right throughout the region. And in the Pacific, it is the Pacific region. Next slide. Now, how do we translate the plan into action? We need to identify platforms that are currently established and use that as an entry point in the areas of surgery, obstetrics, and anesthesia. So for example, in the Pacific, one thing that's beginning to really take off is cervical cancer screening. It's something that the gynecologists have put their foot into the public health, and we need to see what they're doing well, how we can actually work that. Diabetes food is something also of concern within the Pacific, where the surgeons working with the physicians have actually begun to push out into the public health domain and actually gain traction. So we need to see what are the platforms that we already have and use it as an entry point into a translating planning into action. Another way is to identify early fixes and early gains that can be used to gain momentum. As, for example, one thing in the Pacific is the need for circumcisions, and it's a cultural and religious need. So making sure that we are able to offer safe circumcisions right throughout the Pacific Island countries. Doing that, we have those early gains. The other important thing is we need to, in the start of it, in the plan to action, we need to push education, research, and innovation as an important pillar, because this will ensure that we mobilize resources in an effective manner, rather than moving forward and then saying, let's develop an education academic pillar. It has to begin with it. And to do this, we need to ask for help. So ask for help, not only from within government, but also ask for help from regional, from training institutions to work with us in developing that pillar. And also we need to work with development partners. And most importantly also, we need to leverage off COVID-19. What can we get through this COVID-19? Can we increase, PPEs and sterile packs and, improve hand washing and minimize antimicrobial resistance? Can we minimize risk of surgical site infections, the development of ICU? Well, let's see what we can leverage off COVID-19. Next slide. And is there a role of NSOAP in the midst of disaster preparedness and pandemic? Oh, there are opportunities. In Fiji, when we had COVID-19 in the community 230 days ago, more than 230 days ago, we had 2 cities on lockdowns. We also had severe tropical cyclone Harold passing through the group. And in that period, we opened 2 bellwether capable facilities. We also sent out our marine vessel Vivuity, which is the hospital ship, once 2 cities were on lockdown after the cyclone, to go and do disaster recon and also provide emergency surgery to those islands that needed it. So we have to understand that both COVID-19 and disaster, they both need safe and surgery, anesthesia, obstetrics, and anesthesia. Now, we also need to ensure that we leverage support for these 2 areas for NSOAP progress. When I say that, I mean that with the COVID-19 pandemic, many countries are able to access support for their health systems. How can we leverage support to NSOAP? Okay, in the disaster, so when countries had a disaster, for example, a major tsunami, whatever, there are many development partners that want to actually support those nations. We need to actually fit the NSOAP into receiving from that support. And I think that's all I have. Next slide. Yeah, so that's it. Thank you. Thank you, Liz.
Great. Thank you so much, Minister Wanga, for that great presentation and for your leadership, both in Fiji and in the entire Western Pacific region. You mentioned the importance of aligning the NSOAP with national strategic plans and generating political will so that the plan is embraced and owned by the government. I just have one question kind of following up on that. As the Minister of Health of Fiji and a surgeon yourself, you've been a key champion of including safe and affordable surgery in the agendas of the region. What messages do you have for other ministers of health, and what advice can you give about the role that the Ministry of Health can play in introducing new initiatives such as surgical care?
As I've alluded to earlier, we have to understand that we have to discuss this as a topic that's already happening on the ground. So even in small health facilities, abscesses are being incised and drained, debridements are being done, episiotomies for deliveries are being done. So we need to actually pursue this in saying, look, there's actually surgery, anesthesia, and obstetrics happening. What we're talking about is making sure that it is safe. And then we are beginning to actually also ensure that in whatever capacity it is done, whether it's in a small outlying facility which is only able to lance or drain abscesses, or to the tertiary center that you may have, that the whole health system, which is the surgical obstetrics and anesthesia health system, actually is safe and accessible, and actually is beginning to build forward. I think that's the way to be able to sell it. If we sell it as a completely new idea, it is very difficult. So I think if we begin from a place of there's already work that's happened, all we're trying to do is actually ensure that we develop quality in the work that's happened, mobilizing quantity to that, then it is easier to accept from the rest of those who are in authority. But if they see it as a completely new initiative, then it has its own challenges, because everybody's thinking about how do we share that pie. So I think that to me that's the important thing, is actually getting everybody who are in the political will, who will be able to draw attention to the cause, to say, look, there's already work happening in this space. All we're trying to do is actually make sure that there's quality and mobilizing quantity towards it.
Thank you very much for that. Our next panelist is Ambassador Mpoki Ulisubisya, who has a background in anesthetics and critical care medicine, and was the permanent secretary of the Ministry of Health in Tanzania during the development of their NSOAP. So he's currently the ambassador to Canada as of last year, but has enormous experience in the development of Tanzania's NSOAP. Thank you very much for joining us.
Well, thank you very much, Liz, for the wonderful welcome and the humbling introduction. I was part to a big team that did a great work, and I was simply riding on their shoulders, for which I'm very grateful to the Lord. I also worked with several people in the audience that informed the progress, and others who made presentations to this forum a few weeks ago. And I'm talking about the Desmond, whose presence in this work, together with that of the Global Surgery Foundation, Safe Surgery 2020, and the Harvard Med School program in global surgery and social change, helped us a lot while we were dealing with this process. I am going to address a few issues that were brought to my attention. First of all, on my background and the role that it played for the development of this process. I trained in the country, and then I worked and specialized in the country. And as a result, I got to see for myself the caseloads in general, but also in the critical care. I trained both in the country. I also was privileged to visit high-income countries, middle-income countries, where I learned. And as a result of that experience and knowledge, we were able to incorporate this in the course of my work while I was training physician, anesthesiologist, and non-physician anesthetist, and also while handling cases in the hospital, but also as an administrator. One of the things that is fundamental in development of a national surgical obstetric anesthesia plan is to study the local situation. So there has to be an innate situation analysis as a pull factor. One has to know what are the kind of diseases that are overburdening the health delivery system, and has to know the rate at which the population is growing, morbidity and mortalities from diseases that those populations are suffering from, and also the population demands, geographically, but also socially. Then there are the push factors. The push factors, I would look at them specifically, number one, as the political will. What is the political dimension doing in encouraging provision of equitable and quality health services? So we need to appreciate the role that is played by the national economic roadmaps. We also have to appreciate the election manifesto from the various governments that sets goals and targets, and also what are the budgetary provisions that are at the disposal of the ministry in this in discharging those responsibilities. Quality assurance routines, and what feedback do they give? Funding interventions, also surveys that are done by both local and international organizations on the local sphere, but also on the international platform. So feedback that comes from World Health Organization, reference to documents that have been produced because of the work that was done, like the Lancet Commission on Global Surgery, what UNFPA suggests, UNICEF, and then other programs that come in to push the space. But also, what are the windows of funding that are available in each country? These together, put with specific measures that are suggested and put in the country, will help in development of a national surgical plan. Now, each ministry has to customize depending on the unique needs in the country where they are. Or one size fitting all does not work. That's why each country has to develop their own plan, cost it, and find ways of implementing. Now, one of the things that we have to appreciate is the fact that there has to be a health policy. So this is one of the blocks in the health policy. And in the case of Tanzania, we had a national health policy, which was a broad roadmap, but we also had specific, the health system strengthening strategy, which was a plan that was put in place that was meant to cover between the year 2015 and 2020. So when we initiated the process of developing the NSOAP in Tanzania in the year 2016, we were simply drawing from this foundation, and on which the SMART goals had to be appreciated as we developed them. And as you can see in the next slide, you know, this cannot be done by an individual. It has to be done by a group, so that you set priorities and you start working on those priorities in addressing the SMART goals, which would be specific, measurable, affordable, achievable, relevant, time-bound, and then it cannot be done by just the ministry and the people of the country. This brings in all the necessary stakeholders. The next slide will be showing you that we even involved the community. And through the period, over 200 individuals took part in this work to make sure that none is left behind. So the thoughts and aspirations of all these individuals were brought together. Now, one of the other things that needs to be stressed here is priority setting has to involve all those groups. Ours were divided in those three groups: clinicians, civil society, NGOs, and end users, together with the government. Now you see, the government oversaw the whole process. So that created ownership at the level of the ministry, because each of the output that were coming or being brought into the writing group, the ministry was represented through and through. And because of that arrangement, it was very easy for us to say this can be accommodated, this can wait, or this is in keeping with what we already have and what we do not. Then we also had to be careful that the local needs and challenges raised by frontline health workers were addressed. And because of that, the Ministry of Health laid down the policies. But in Tanzania, we have a two-pronged approach to delivering health services. the Ministry of Health and the referral system under its umbrella. But we also have the President's Office, Regional Administration, local governments that mans all the facilities or overseeing the facilities that belong to the local government bracket. Because our system is devolved, meaning that it's much more closer to the people. We also brought in the Ministry of Finance. So they see how the process of development took place, and the funding could then be explained so easily, rather than just developing everything on our own and sending documents to them requesting for funds, which becomes very difficult, as one would need to convince them. Feedback is very important, was important, is, and continues to be important from those that provide services, because this program is customized to meet their unique needs so as to improve the outcome end of the day. And because one of the things that was identified was lack of manpower, this is one place where it is required at all times. So no national strategy can work without those for whom it was intended to provide a regular feedback. But also the ministry has to provide room for monitoring and evaluation in its framework of follow-up of the services that are delivered by the ministry. The other aspect that needs to be mentioned about here, next slide please, is the leadership. Next, the one that has a pyramid on governance, that would be the best, okay, because all these explain the others, all right? So the governance is very crucial because it creates visibility and ensures there is a constant accountability. Health delivery system in the country of Tanzania follows the description that are projected. We have the community where we find individuals, and all health conditions, begins with the family, within the family. So interventions begin there, and that is where the community health workers work very hard. Then we have the dispensaries. This is the first point of call. We have health centers. These health centers will serve a population of up to about 50,000. Dispensaries is about 1 to 10,000, but health centers will go up to about 50,000. Then health centers in a district would refer their cases to a district, and through all this process up to the level of the nation, there is a reflection of what the NSOAP dictates or requires them to do. But to make this real, the Ministry of Health in the Directorate of Curative Services has a specific individual. We call them a focal person that oversees the implementation of the National Surgical Obstetric and Anesthesia Plan. Their duty is to ensure that it's interpreted properly and any challenges being raised receive appropriate and immediate attention, and involves other stakeholders that will be very crucial in seeing to it that we do not divert from the agreed roadmap. Then we have the Directorate of Preventive Services. This is very crucial in our case because the services of reproductive, maternal, newborn, and child health follow under the auspices of the Directorate of Preventive Services. So these two then work to ensure that whatever has been agreed is carried out as required. When all these things are put together, then what is seen in the next slide will be the experience in all countries. There is a writing, publication, and then you launch. After the launching is the implementation. Now, the implementation will depend on the availability of funds. Now, but it's not the only one, because there are certain interventions that do not need the hard cash. It's just a change of attitude. Those must be enforced much earlier. And then where funding like infrastructure development, health commodities acquisition, development of IT system to inform the training, but also data collection and the connectivity and the supplies, the supply chain strengthening in the country. This takes some time, but they must be a part of the checklist to ensure that none is left behind. I want to thank you for the opportunity, and I'll just pause at this point.
Thank you very much. I think, Zach, you're going to introduce our next panelist.
Yes, thank you, Dr. Ulisubisia, for that great overview of the development process of the Tanzania NSOAP and for those key messages. It is my pleasure to introduce our next panelist. Dr. Ramasirabo is the former Rwandan ambassador to Japan. He's a clinical professor of urology at King Faisal Hospital in Kigali, Rwanda. He's also a fellow of the College of Surgeons of East and Central and Southern Africa. Dr. Ramasirabo was also instrumental in the development of the NSOAP in Rwanda, was part of the steering committee for the NSOAP, which was one of the first NSOAPs to be developed, and he'll be sharing some of his lessons learned from this experience. So welcome and thank you for joining us.
Thank you very much, Zach, and thank you all of you for inviting me to this panel. Indeed, I was part of the team that developed the NSOAP in Rwanda with the support of the Ministry of Health, of course, but also from Harvard PGSC fellows. This took place in 2017, and we were very happy that the Ministry of Health was already in the process of developing safe surgery to the population all the way from 2015, when Rwanda, together with 9 other countries, sponsored the WHO declaration 68.15, if I'm not mistaken. And so 2016 was the time really when this process started. I'm going to present, go back to the previous slide. Yes, I'm going to present on these 2 points that has been suggested to me to explain how Rwanda moved to the development of NSOAP and also the other aspects, specific aspects that have been highlighted. So next slide, please. Next slide. Yes. The advocacy was really by the Rwanda Surgical Society, and we were very fortunate that the Ministry of Health was prepared to buy in immediately. So these took place in 2016, 2017, and the ministry, together with the professional association, the Rwanda Surgical Society, the Society of Obstetricians and Gynecologists, as well as the Rwanda Society of Anesthesiologists, as well as the fellows from Harvard, we sat together in the ministry and came up with a strategy. The first thing that was done that time was the setup of National Steering Committee with all the stakeholders, the Rwanda Ministry of Health, the Biomedical Center, the Ministry of Local Government, the Rwanda Social Security Board, the Professional Association, nursing, midwives, the university, the teaching hospitals, the Private Medical Professionals Association, the University of Rwanda, the College of Medicine and Health Sciences, referral hospitals, district hospitals, and Harvard. So this steering committee sat together, and next slide, please, and develop a strategy. The first thing that we started with the national baseline data establishment. This was carried out in all Rwanda hospitals. All Rwanda hospitals were visited by teams of surgical residents. It took about 3 weeks. They went in all hospitals, collected data on surgeries, unmet needs in surgeries, looked at the cost of surgery to patients, including the catastrophic expenditure, the impoverishment expenditures, evaluated this to talk to the to the nurses, talked to the administrators, looked at the issues really brought forward to the establishment of a proper system to safe surgery access. After this exercise that took about 3 weeks was the data processing. This still was done by residents and Harvard fellows. After this, we had 2 drafting workshops with the extended National Steering Committee that was followed by costing workshop exercise with mostly the Ministry of Health and other partners. The validation and official launch was in 2018. Next. So now, it's very, very important that you have the Ministry of Health taking the leadership. In the case of Rwanda, we have this health information system, HMIS, which is a web-based system, the H2S2, collecting data from all over 700 facilities in the country. They collect all kinds of data, and they can provide reports all the time. It is an automated facility that really is important for being able to monitor the implementation of any program in the country, including surgical indicators. So it was really a very good opportunity to set up, the monitoring system on the output of hospitals in terms of safe access to surgery. Then detailed NSOAP indicators were introduced in the HMIS, but obviously this is one thing to introduce these surgical indicators, but making sure that at all levels of the health system, everybody understands what to do and actually be able to report as needed. This requires constant sensitization and feedback from central level to local level in terms of infrastructure development, service delivery, workforce, finance, information management. Next. Now, looking at workforce development in Rwanda, this is probably one of the most important aspects that we had to consider to make sure this NSOAP is achieved. The baseline data had showed that this is the most important factor that Rwanda needs to address to be able to implement the NSOAP. As per the Lancet Commission on Global Surgery 2013 definition, NSOAP refers to specialists in anesthesia, surgeons, obstetricians, and very often you find going at this definition, it will be difficult to really provide the basic surgical needs. When we evaluated this, according to this definition, the SIO density in Rwanda was 1.3 for 100,000. Now, the ministry decided that maybe we should extend this definition to non-surgeons, non-specialists, including anesthesia technicians, GPs performing surgery in rural hospitals, GPs performing cesarean section, and other non-physician providing surgery. So this brought the extended SO density to 8.03 per 100,000. You'll notice also that the the bellwether procedure were extended to more specialties such as NT surgeries that were also included in the plan. When we monitor and see what we having today after 3 years, going by the extended definition of SAO, we are happy to see that we can estimate the density of SAO per 100,000 to 12 because of training in different areas of surgery, obstetric, anesthesia, and also non-physician trainers and non-surgeons trainees that they are able to carry out more cesarean section and basic surgery. And when you look at the volumes, in 2017, our volumes were as low as 786 surgeries per 100,000. And today, going by the HMIS figures in 2020, we have moved to 1,128 volumes, surgeries per 100,000. It's still low, but you can see really there is improvement. Next, please. Next, yes. Now, I was requested to talk about pediatric surgery aspect in NSOAP. Can you go back? Yes. I was requested to talk about pediatric surgery aspect in NSOAP. It's a very sensitive issue indeed, because quite often district hospitals, they lack anesthesiologists and anesthesia machines. Pediatric patients tend to be most often transferred to higher levels, even for not serious major conditions. So it's very, very important that that issue, given the number of pediatric patients in countryside, it's important that issue is considered. Current emergency pediatric surgery is carried out by general surgeons, leaving elective and especially congenital conditions on the waiting list of the few available pediatric surgeons. Pediatric surgery training is part and parcel of Rwanda NSOAP. The availability of anesthesia machine is also high on the NSOAP agenda. The training of more anesthesiologists, as well as special training of senior non-physician anesthetists in pediatric anesthesia are part of NSOAP workforce. Next, please. Next. How can the system then, sorry, can you go back? How can the NSOAP become a cross-cutting strategy that strengthens the overall health system? This is clear. In the plan, for example, when I look at the infrastructure development strategies, a few important things that are highlighted in the plan is improvement of connectivity and water network to ensure uninterrupted power supply, UPS, to all hospitals to stabilize the electricity. Increase of functioning operating theaters per hospital. The lab, radiology, pharmacy improvements. The optimization of surgical bed capacity and the incremental number of functional anesthesia machines. The expand intensive care unit, ICU services, at least 4-bed unit at each hospital. So these will definitely have an impact on the whole hospital, irrespective of specialty or patients. The service delivery strategies also show how the NSOAP will really reflect on the whole system in the hospital by prioritization of redistribution of physicians and the provision to district, regional, and referral hospitals more staff, surgeons, anesthesiologists, obstetricians, and gynecologists, and sometimes orthopedic surgeons in some hospitals given the the disease burden. You find some hospitals in the countryside along highways are getting more trauma than any places in the country. So those ones get special attention. Then also we formalize the mentorship between the referral hospital and district hospital to empower the capacity of the local staff to feel comfortable in performing some duties. Standardized procedures offered at provincial and district hospital. Somebody talked about the accreditation system. The government, the Ministry of Health, has actually extended an accreditation program to all hospitals in the country. It's a very long process, quite expensive, but the most important thing is to start and make sure everyone is in the process. Accreditation really is the thing that helps to get quality into what we do. Also, we increase the volumes of outreach surgery to improve the quality of surgical care and also to get more access to specialist care in countryside. The same for the workforce development strategies. Everything really brings, the people working in the district hospitals into the constant capacity building. Train the GPs to perform bellwether procedures where we have no surgeons. So this is something that has been taking place over the years, and you can see really the numbers coming up. Next, please. Next slide. Now, I was asked to see how can the ministries of health manage stakeholders from different backgrounds and disciplines effectively. So the most important thing is for the ministry really to show leadership right from day one and throughout the implementation. And I think the ministry has the tools to ensure that that implementation is monitored and it's real and it's reported on a regular basis at all levels of the management. Identify and support champion professional organizations and individuals. So it's extremely important to have the professional organizations involved in the implementation, but also in the monitoring. Very often, surgeons, obstetricians, and anesthesiologists are the ones that are able to push these programs. They know each other. Many of them have been trained by their mentors in the referral hospital and teaching hospitals. They have the same networks. They are able to communicate in WhatsApp groups. They communicated about cases that are seen and were able to, through discussion, to work on them or get them transferred on time. Of course, we need to involve professional organizations at all levels of the hospital, training institutions, development partners, right from the beginning. Develop specific national policies to ensure that there is a standard reporting system across the health system. When all hospitals are involved in the accreditation process, this really becomes easy. The reporting forms are available to everybody, and if the ministries are able to develop electronic information management system, this will ease even further. The HMIS is operational. The electronic medical record system in the hospitals are not yet automated, but it is utilized by all hospitals, and the reporting is sent into the HMIS. And of course, important to integrate the NSOAP, National Health Sector Strategic Plan, as it was done in Rwanda in the Strategic Plan 2018-2024. Next. Thank you very much for your attention.
Thank you very much, Dr. Ramazurabo. We might move on to our final panelists and see how much time we've got for questions at the end. So it's now my great pleasure to introduce Professor Emmanuel Arme as a paediatric surgeon, professor and chief of paediatric surgery at the National Hospital in Abuja. He's also a founding member of the Global Initiative for Children's Surgery, chair of the NSOAP, and was chair of the NSOAP Committee for Nigeria, and a member of the Lancet Commission. So thank you very much for joining us, Arme. And in January in Johannesburg, which seems like about a decade ago, there was a lot of discussion and some criticism of countries for not including paediatric surgery in their NSOAPs in the initial formulation. So very interested to hear your thoughts. Thank you.
Thank you very much, Liz, for the introduction, and thank you for the opportunity to share our experience. Next slide, please. Next slide. Right, so I'm going to try to quickly share a very practical experience about the NSOAP in Nigeria. In Nigeria, we run a healthcare system that is both centralized and decentralized. Centralized in the terms that the federal government creates most of the healthcare policy through the Ministry of Health. And obviously there are a large number of competing healthcare interests at that level. And we have about 36 states and the federal capital who can also create their own healthcare policy, but they are also involved in implementing the policies created by the federal government. So we have like a hybrid kind of system. Next slide, please. Right, so our NSOAP process, we call it the strategic priorities for surgical care. Next slide, please. Right, so even though our approach to the NSOAP process was centralized, but it was kind of a bottom-up approach. So the initiation of the entire process started from the professional societies, and after they had agreed on the need to create a surgical plan, they engaged with the Ministry of Health. We took it off from there and took up the leadership role and the coordination of the whole process. But the entire creating the need came from the professional societies. And I think very importantly, I must emphasize that in terms of funding, we had zero funding for the entire process. And that was very challenging. But because the professional societies were determined that there needed to be a plan, and the Ministry of Health also then was in line with them, it was possible for us to get around the difficult funding issues. And how we did that was that the baseline assessment was entirely conducted by the professional societies, along with a few SAO individuals. In terms of funding the meetings, we have a national postgraduate medical college, which is a surgical training college, which is government funded and has its own budget. So they were able to host all our meetings, and that made it possible for us to create a plan. We did have technical support from international partners, including PGSSC and the University of California at Davis. Next slide, please. So these are some of our priorities, our strategic priorities. I won't go into details of that, but I think the high point is the fact that we agreed that there needed to be a national children's hospital, because children's surgical care was really one of the key components of our plan, and creating a national children's hospital to take care of the training of all the providers that needed to function at the lower level hospitals was very important. So that was one of the key aspects of our plan, our priorities. We also quickly realized that at our current SAO level of 1.6 per 100,000, it was impossible. Even it was going to be impossible even by 2030 to get to 20. So our 5-year plan was really to raise that SAO from 1.6 to 5 per 100,000 population, because that was a little more realistic. Next slide, please. Right, so some of the unique aspects of our plan, as I pointed out, was inclusion of children's surgery. More than 50% of our population are children and adolescents. And we felt that if children were not specifically included as a specific component, they were going to be forgotten down the road, as has always happened. We also realized quickly at the beginning of the plan that nursing was one of the weakest links in the outcome, in our surgical outcomes. And there was already so much gap between progress in the training of SAO and the training of nurses that needed to be involved in surgical care. And that was why, and luckily we had a very strong nursing society, and we worked with them to specifically include nursing to make sure that that wide gap between nursing care and the actual surgical care is narrowed, and that should help in improving our outcomes. And for us, there's a very strong role for the professional societies, because again, we realize that in terms of the implementation, there's just so much the Ministry of Health can do without very strong participation and really taking the lead by the professional societies. That was going to be a problem. So in terms of implementation, we started implementing this year. And I think one of the things we were able to achieve is creating a budget line for NSOAP implementation in the budget of the Ministry of Health, even though at the moment that amount is small. But we do think that with the budget line there, we can progressively increase it such that every year we know that we have something to help with implementation of our NSOAP. We took a pilot approach in terms of the implementation because we realized it was going to be unrealistic to implement the entire plan in one go, because we still needed to convince to get a lot of support from the government. So our pilot implementation means that we are implementing the entire plan piecemeal. We have created multiple entry points. And one of the things that has done for us recently, we had one of our development partners come up and say, look, we want to be involved in the NSOAP implementation, but we simply don't have the resources to do so much. Which aspects can we take? And they chose to create an electronic, ongoing electronic record system that makes it possible for us to capture everything electronically about surgical care. So the multiple entry points that we have created is making it a little bit easier for development partners to get involved. I think the current challenges and threats we see is funding is always going to be a problem. But with COVID now coming on, it seems that surgical care is going to be a big collateral damage. And one of the things we are trying to do is to make sure that despite what is happening with COVID, we can keep surgery and surgical care on the table of our country's public health. And we can actually leverage, as one of the speakers pointed out, we can actually leverage COVID to improve and get resources for surgical care. Next slide, please. Right, thank you very much.
Great, thank you very much, Dr. Ame, for that great presentation and for highlighting the importance of children's surgery throughout this process and your experience with that. I'd like to direct the next question to Ambassador Mapoki. Ambassador Mapoki, you were permanent secretary at the Ministry of Health of Tanzania when the NSOAP was developed. I was wondering if you could describe the process of engaging with the Ministry of Finance and how you were able to get buy-in from the finance ministry and develop a fundable plan that was aligned with their priorities.
Oh, thank you very much, Zach. These are human dynamics. So the relationship that exists in society must not be left there when we are doing work for the government, because after all, the government is by the people, for the people. So when this thought was being molded, we made sure that the Ministry of Finance was invited to be part of the process. So ownership started from the beginning. So it wasn't a one-time event when where we invited them when costing was the exercise that we were doing. So they were part of the process. May not have been the same individual, but at least they were represented all through. And I believe they shared notes, because those who took part in the audience will agree with me that we did not get any resistance from them. And bottom line is we were drawing a roadmap that will help us to deliver efficiently quality health services in surgery obstetrics under the auspices of anesthesia, supporting both fronts. None of us chooses when to fall sick and which kind of disease we are to suffer. So such kind of arguments were very plausible, and they were very convincing. But number two, the permanent secretary in the Ministry of Finance was a good friend. So every time when we had meetings, high level, interministerial technical committee, I would always whisper, your candidate for the job is doing a very good job. In the process, encouraging him to keep supporting the process. That way it worked very well. To this day, it's been reflected in budgetary allocations of the country, because they know that we are not just introducing something new, we are simply broadening the base on which to justify the need for more money in funding the healthcare system in the country.
Thank you very much for that. We've had an excellent question from the audience, which I would direct initially to Professor Ahmed, but I'm interested in others' thoughts as well. And that is, what challenges and successes regarding the integration and full engagement of maternal, newborn and ONG or OBGYN, the OBGYN community into the safe surgery agenda have you encountered? And I'll direct that to you initially, Professor Ahmed, because I'm so impressed that Nigeria has an extra N in the NSOAP process and has included our nursing colleagues right from the start. So thank you.
Thank you. I think one of the challenges, especially about OBGYN from the beginning, was that the OBGYN community as a group already had very strong advocacy system and society. And they were already involved in doing so much work over so many decades in improving maternal health. So when we started, the question from them was like, surgeons, you are going to drag us backwards. We are already doing so much on vesico-vaginal fistula, on obstructed labor and all that. And it took a while to convince them, but once everybody realized that, look, what we are focusing on an integrated and a very coordinated approach, rather than having a fragmented kind of approach that wastes some of our efforts and resources. And once they came on board, that became a little bit easier for us, and they were excellent. They had so much contact within the policymakers, and they made it possible for us actually in terms of advocacy to reach where we wanted to reach. In terms of nursing, I think we thought that was very crucial, because especially when our OBGYN colleagues came on board, it was like a lot of the things they do requires nursing. And if nursing was going to be left out, that was going to be a problem. And for me, as a pediatric surgeon, a lot of our outcomes has to do with how much effort our nursing colleagues put into the work. And we quickly realized that we just need the nurses. And there was already so much gap. So working with the nurses that has made it possible for us to really have a more comprehensive approach to our NSOAP. And as we begin to implement, again, I think one of the things that nurses do very well is advocacy. And they are actually our strongest voice in advocating for our NSOAP. Thank you.
We've had another excellent question. Maybe Minister Wanganabete, would you like to field this one first up? What advice from the Ministry of Health perspective would you have as to how best to integrate the NSOAP into the National Health Strategy? What pitfalls do you perceive might be encountered in that process?
Thank you, Liz. I believe all low middle-income countries and smaller and development states, obviously the goal at the moment is heading towards the SDGs 30 and the Sustainable Development Goals, and UHC plays a very important component of that. And I think we all agree that the push is actually to ensure that safe surgery, obstetrics and anesthesia is a very important component of UHC, and that UHC penetration that we want to see. From a Fiji perspective, it's about making sure that all our 220 facilities, all throughout our nearly 100 inhabited islands, they have the capacity to be able to be safe vehicles for safe surgery and obstetrics and anesthesia. It doesn't mean that one isolated facility will be the place where we're going to do high-level care, but it is the access to high-level care is making that is an opportunity for access to high-level care. And I guess the challenge that happens at times is, as I've alluded to earlier, is understanding that there's already a platform that exists. And that platform that exists is something that we can draw on. So it's about slowly introducing the topic into a broader topic that currently exists. And, how can we then ensure that the NSOAP strategies become a part and parcel of the growth of the Ministry of Health. And having said that, because all the nations are heading towards SDG 30, they also have their own development plans. The old ministries will have their own operational plan. So then it's about making sure that we then say, look, safe surgery, obstetrics and anesthesia is part of the UHC mandate. It's a global mandate. And because it's a global mandate, the large development plan mandate of the nation, which aligns itself to the global mandate, should also include safe surgery, obstetrics and anesthesia. And so we can work it from the bottom up and we can work it from the top down, but just making sure that we align to the strategies of the global mandate, and also because countries around the world want to align themselves to the global mandate, to their national mandate. And once we're able to fit it into that and align it into both from a ground-up approach and from a top-down approach, and then we have synchrony, and then it becomes a huge wave that will take us along. I think that's the important thing.
Great, thank you, Minister Wanganabete. For the next question, I'd like to ask Dr. Sobel about something that he mentioned in his presentation. You discussed the operational shifts of the action framework for safe and affordable surgery, the first of which was identifying and convening stakeholders. I'm wondering who you consider the relevant stakeholders to be, particularly outside of the health sector, and how can ministries of health achieve broad engagement among them?
Thank you very much. Excellent question. And I think that every country is going to be a bit different on this one, but an obvious one is going to be the ones that hold the purse strings, your Ministry of Finance, your Ministry of Planning, Different countries are going to have a different one that's going to be the key one that does that. But if we don't get them in from the beginning and then we go begging for money from them, we're not going to get a very receptive response. I'd like to, if it's okay, I'd like to kind of add one more thing to the mix and the dialogue. And that's that I think the most, for me, the litmus test of a sustainable program is when there's domestic financing of it. I have found that across every program, that once you get that one thing, then the program in the country takes off rapidly, and then other things will follow along very quickly. But to get that, you've got to get them in right at the beginning, at least at a stage, you know, when it's in its embryonic stage, and they feel that this is something that they're a part of, they're going to be quite committed in the long term. But there's many different ones that you have to look at. In some countries, the ones that hold the purse strings are going to be, you're going to have insurance companies. Sometimes it's nationwide national health insurance, and in other cases, it's going to be private. You got to figure out how to get these things incorporated into those standards. Maybe I just stop there, and if you have further questions, I'm happy to answer it.
Thank you, Dr. Sobel. Thanks, Howard. That's great. I think we probably need to wrap up. Everyone's getting tired. But one more question. Dr. Ramasarabo, just thinking about your experience with the NSOAP in Rwanda and the current opportunities for promoting surgery as a cross-cutting service and strategy. What do you have any suggestions based on your population needs on how we can strategically use that cross-cutting aspect of surgery to promote the development of our NSOAPs in other parts of the world?
Thank you, Liz. I think when you look at the implementation, we realize that the NSOAP does not come as a standalone plan. It is part of a number of programs already being implemented in the country and funded by various donors. The most important thing is really the human resources. If the funding for infrastructure, which is already taken care either by government budget or development partners that have decided to support a number of districts, you find that you actually find a lot of funding already committed in various programs. So the role of the ministry is really to make sure that the funding also addresses key issues in access to safe surgery. For example, to give an example, there is a partner country that supports about 15 district hospitals in the country. We just talked with them and realized that the funding required for key NSOAP infrastructure, like getting water, getting electricity, expanding theaters, getting anesthesia machines, getting oxygen cylinders, it was a small part. And it was also realized that all that funding, that support, also supports other departments or other kind of health issues. So the role of the ministry at bringing everybody together for a concerted effort in the support of healthcare delivery is very important. Again, like my friend Emmanuel from Nigeria was saying, one thing that is important is, the professional societies, of course, there is a cost, to providing care, training, but professional societies are naturally ready to, own surgical access, NSOAP objectives for their countrymen. This is something we realize. When we talk of increased access, the professional societies, irrespective of disciplines, they work together. The nurses, the technique, non-physician anesthetists, how do you call them? The medical assistants. They participate in programs such as safe circumcision. They give and they are proud to be able to do that. I think if we're able to harness all the energies that are out there, definitely we can achieve a lot, even with limited funding. I don't know whether you addressed the question that was asked me. Thank you very much.
Maybe hand back to you, Jeff, for some closing remarks.
Well, thank you, Liz, and Zach for moderating this session. It has been an amazing discussion, and although it's already an hour and 45 minutes, I think we could have probably kept going. There's so much important information here, and I just want to thank all of the panelists. This has been really fantastic. And just to touch on a few important points that were made by several of the panelists, I think the whole point of how COVID has redirected the attention of the world back onto health is so important. And as Dr. Wakanabedi said, we can use that to capture the attention of the donor community and the country priority spending to refocus on building strong healthcare systems. And really, when we strengthen surgical capacity, we strengthen the entire healthcare system. There's so much overlap. So I think we need to remember that, and thank you for those points. The other important point is that this is such a key component for universal health coverage. And without it, we keep saying this again and again, but we need to tell this to the Ministries of Finance, the Ministries of Planning, as has been mentioned. And I really liked your point, Howard, about how your litmus test on whether this is going to gain traction is whether we get domestic finance involved right at the very beginning. And Mpoki, you said, having the Ministry of Finance people at the table at the beginning is so important. So I just want to highlight some of those key features. The other thing that really struck me is this is a cross-cutting sector. We're talking about nurses, we're talking about midwives, obstetrics, anesthesia. All of these different areas are so important in this process. So I don't want anyone to forget that. So I just want to thank you again for such an amazing discussion. Thank you for your presentations. And, this has been a really successful seminar. I just got notice from our team that with Zoom and Facebook Live, we've had over 500 people watching this session. So that's one of the best of the 5 sessions so far. So good job, guys. We're really thankful. And it just is a testimony to how important this whole topic is moving forward. So on behalf of the United Nations Institute for Training and Research, the Harvard Group, Program in Global Surgery and Social Change, Kids OR, thank you, Rosemary, for joining us, and J&J, of course, for sponsoring this. And on behalf of the Global Surgery Foundation, thank you very much. And please register for the next one. It's going to be another exciting discussion in 2 weeks' time, and you can get that information off our website. So thank you very much, and have a great day, and keep safe. Bye-bye.
Bye-bye.